Okay, so good afternoon, everybody. Welcome to Neurology Grand Rounds. It's a pleasure to introduce Miroslav Backonja, who's going to be speaking with us today. Misha is originally from Yugoslavia, or the former Yugoslavia, where he did his medical education at the University of Zagreb. He's been in the United States since '83 as an intern and then a resident at the University of Wisconsin-Madison. He's been part of the neurology department at the University of Wisconsin for most of his career until recently, when he moved to Seattle to work for CRO, which is a clinical research institute that directs clinical trials, pilot and phase 1 studies to treat neuropathic pain. Dr. Backonja's research and career has been characterized by a deep interest in treating neuropathic pain. He's been involved in numerous industry and academic funded studies to evaluate and treat neuropathic pain. And he's affiliated with our department now, really as a volunteer working in the pain clinic here. So we're really happy to have you in our department and to hear your talk today. Thank you.
Thank you. I really appreciate it. I really want to extend my sincere thanks to giving me a home now in Seattle. If I have a little accent, just to let you know that I had it all in my life. But I was actually in my own high school. My colleagues would say, "Where are you from?" And I said, "Well, down the street." And they said, "Oh, you have an accent." So when I was born in Banja Luka, but then I lived in Zagreb, which is now a different country. I came from originally Yugoslavia, but now it's 7 countries. And so kind of in the background of where I'm from, because that's frequently what people ask me when they hear my accent. So it's always like a double or triple question, because I was in Wisconsin for more than 2 decades as a resident and a fellow and then a faculty, where I did 5 years of basic research and then switched to clinical research and clinical trials. I was trained formally in pain management and multidisciplinary pain clinic at the University of Wisconsin. But you can imagine, as soon as people know that you do pain, although I was a neurologist, my clinic was full of, guess what? Patients with pain problems. And so one of the things that happened to me in a clinic was I would face patients with pain problems like everybody does. But then I go to a basic science meeting like neuroscience or International Association for Study of Pain, and you see all these wonderful mechanisms and you see new chemical entities, which is potentially drugs, and then you go to clinic and then all you prescribe is morphine, aspirin, amitriptyline. I mean, things that have been around for 200 years, like there's a problem there. So 5, 6, 7 years ago, I started looking around to where do I go to really make things. I mean, this is really not sustainable. And so I went to NIH and I told them about my frustrations. I really wanted to help move things from the lab to clinic. And they said, "Well, if you want that, you go to FDA." So I did go to FDA, and they said, "Well, this is exactly what we need, is a person who has a clinical experience in pain and who's interested in this." But meanwhile, I meet a colleague, Dr. Lynn Webster, who had a small CRO in Salt Lake City, and he pretty much convinced me that really action is in the world of CROs. So 5 years ago, I switched the gear and went to first small CRO that got acquired by a bigger one. And now actually I moved again to Worldwide Clinical Trials. That's the name of our clinical research organization. And my task in this new position is to advance how the clinical trials are done to advance transition from preclinical to clinical research. Because one of the big questions is everything works in rats. If you look at all the studies, when you go to basic science meetings, everything works in rats and mice. But when you go to clinic, guess what? We still have to deal with the scourge of opioids in the absence of really good therapies. So that's where I'm at. And when I moved to Seattle, I told this company, my management, I said, I want to stay in the clinic. And now I'm one day in a clinic on Fridays at the pain center on Roosevelt. And just kind of as a matter of introduction, area of my interest is certainly neuropathic pain as a neurologist. And I'm also interested in small fiber neuropathy as well. And I'll make some reference to that as I go. I really want to make this interactive. So if anybody has any question at any time, please raise your hand. And I really don't want to leave anybody kind of in dark. Just as also another matter of introduction, and I don't know how many scientists are here.
Misha, there's two microphones there in front of you, one around your neck and that one. Push the one in front of you down so that there's no echo. There you go.
Is that better?
Yeah. I think
sorry. Good. I'm glad.
Yeah, I mean, it was making your special accent even more
Accented.
resonant.
Yes. Good. If I don't know how many scientists are here, but in science there's always a question, what's your question? My question when I started my career in neurology and when I was in the lab and later switched to clinical human research was how can our tools perform that we use in pain management perform to advance the research and practice. And unfortunately, I have to say, after 2 decades, those tools don't perform well. And I'm referring to tools that we can use in clinical medicine, in neurology, and that is, how do we assess symptoms and signs and make that be an important part of research. But things are improving, so I hope if you can leave this presentation with anything, at least is an impression that there is a progress. Two people who influenced what I have done in my career are these two people. First one is Jose Ochoa, who is the first who published normative data for sural nerve biopsy. Actually, in Holy, we had a discussion, what's the role of sural nerve biopsy in diagnosis of neuropathies, and in the developments of new tools for assessment of small fiber neuropathy in particular, with skin biopsy, there's a less need for sural nerve biopsy. He's the one from whom I learned how to conduct quantitative sensory testing. He's really a master of that and has published a lot of stuff and really established basic principles. The second person is Charlie Cleland, who is a psychologist and who has developed a brief pain inventory as a tool for assessment of pain and in its full complexity. And actually, he was inspiration for me to develop a neuropathic pain questionnaire tool that's used for assessment of neuropathic pain. And these are my publications that led in results of my work, and I'll make a reference to this as I go. Let's now to the topic of the objectives of my presentation is Dr. Ransom, when I talked to him half a year ago, introducing myself to him, his comment was, well, can you tell us a little bit about the mechanism? So we can have a whole day symposium on that topic, but I'll probably just give you a little bit of a taste. What is the range of pain mechanisms and the implication on neuropathic pain in particular? And then trying to follow the principles of your grand rounds is to have a clinical implication. What does it mean? How does it translate in clinical practice? I'll make a reference to that. And then I'll make a reference to some of the development in quantitative measurements. And ultimately, what I would like to leave you with is to impress on you that really the progress in pain management will take place only when neurology gets more involved. And I'd like to have discussion about it. Everybody's familiar with the scourge of opioids and opioid overdose deaths. You had probably Dr. Taubin talk to you, and Dr. Brett Stacy was here only a couple of months ago and talked about the grim statistics of overuse and abuse of opioids. And now everybody is pulling away from prescribing opioids. But this is just what I got in an email this morning, is this recent survey of patients identifying that the increasing number of Americans with chronic pain experience barriers to access of pain medications, and nearly half of them are contemplating suicide. So we're going from one crisis to another crisis. And we can have a practical and philosophical discussion why patients with chronic pain experience all the difficulties. But I'll hopefully give you at least some view how a good diagnosis can really lead the way in treating these patients appropriately. Because most of what these patients need is recognizing that they do have a problem, may not be obvious, may not be taken on an X-ray or documented on EEG or EMG, but they do have a problem. And a lot of times it's neurological. Just as a matter of kind of brief overview, again, everybody has an idea and experience of pain. And everybody has, and again, probably all of you have had some neuroanatomy about the pain pathways. But it really took me a few years of studying this to realize that this is not a singular phenomenon. This is, yes, the event can happen in periphery like touching a hot stove, but there's a whole host of events that are termed transduction. There's a whole, a long list of neurotransmitters and neuromodulating neuroactive substances that initiate this peripheral nerve impulse in peripheral nerve that's called peripheral transmission that leads to then propagation of the signal of tissue damage or disease that is happening in periphery that triggers central processes at the level of synaptic transmission. Things get pretty, if you think this was complicated, things get really complicated when you get to spinal cord because you have a central transmission as well as the sending modulation because it gets activated when signals arrive to the brainstem. And I know there are medical students and residents here, so there's a question. What part of spinal cord does the central transmission takes place? Any volunteers? I'll give you a hint. It's a spinal thalamic tract. Where is it located? Which part of spinal cord if you look at through the section? There are 4 quadrants. It's anterolateral quadrant because the signals right, good answer. So when signal comes to the dorsal horn, it transverse the spinal cord and go through anterolateral. This might be a question on board, so for the residents might be a little bit of a review. But things get really quickly complex when it gets to the brainstem, and then especially in the thalamus and cortex, when there's a number of events that take place. This is just a simple signal transmission, but things get very complex when there's a tissue injury, especially when there's injury to the nervous system. And in more general terms, the phenomena that happen in periphery are called peripheral sensitization. And what things that happen in central nervous system is called central sensitization, like duh. But yeah, but I'll make a reference to that because some of the developments are referring to the fact that we can start to assess these events, whether they happen in peripherally or centrally. Just give you a little taste of what the nerve terminals look in the periphery. Every type of nerve fiber, so large myelinated versus A delta, which are lightly myelinated as opposed to C fibers, have a whole host of receptors that are highly specialized, like TRPV1 is highly specialized and predominantly located on C fibers, transmitting the signals of acidic environment, heat, and particularly responsive to capsaicin, and also responsive to tissue injury. So you can see that if you look at from the perspective of how do you develop therapeutics, the list gets pretty quickly very large. And unfortunate part is that we really do not have a clue from the basic science yet which of these compounds really is most relevant in development of chronic pain. In particular, there is some indication that nerve growth factor might have a negative effect in development of chronic pain. And actually, a large clinical trial conducted 20 years ago, they clearly demonstrated when nerve growth factor was given to a patient with diabetic neuropathy to develop, to actually help repair the nerve damage from diabetes, actually those trials had to be stopped because patients develop severe neuropathic pain. Now there's actually therapy that are being developed using anti-NGF antibody to block these receptors. If you look at the primary efferents, we think usually in terms of single fire of wires in the wall, like our telephone wires. But you can see that this is actually a network in very close interaction between the not only nerve fibers themselves, but also with the surrounding tissues, in particular fibroblasts and the other tissues, a very close interaction with the vascular system. There are very specific properties of the neurons in their response to injury, in particular spontaneous activity and then overexpression of sodium channels. When we get to spinal cord, the things get fairly complex, and we start to meet usual suspects such as glutamine and GABA as primary amino acid transmitters. On this list, what's missing is neuropeptides, so like serotonin and noradrenaline, which are really important in modulating the transmission of and get upregulated in some resistances and dysregulated in others in development of chronic pain. And then certainly neurotraffic factors play a significant role, but what we're realizing is that glia really is very reactive in the terms of injury, and also there's evidence from University of Colorado that the glia becomes dysfunctional in terms of chronic opioid exposure. So it's kind of paradoxical to think that glia contributes to hyperalgesia as a result of exposure to opioids. And again, like everything else in science we try to delve to this deeper, to this ultimate molecule that would cause the pain. In this case, we're looking for the pain gene. Turn out that there is over 400 genes that participate in phenomena of nociception, meaning the pain transmission, to analgesia and everything in between. So as you can see that the picture is fairly complex. There are certain genes and their biochemistry and downstream effects that are well understood in some cases and then others. The best example is what we have learned about sodium channel SCN9A, and this has been highly publicized. This is the work of Stephen Waxman and many others, demonstrating that in cases of erythromelalgia, there is a gain of function, that there's overexpression of sodium channels in patients with this condition, which is a form of small fiber neuropathy in its idiopathic form, although there are secondary forms of erythromelalgia. On one hand, there's a gain of function in erythromelalgia, and actually it's kind of interesting. A couple of weeks ago, I saw my first Washington patient with this condition, well, I was trying to figure out how to help him. And the other hand of the spectrum is congenital sensitivity to pain, or CIPA, whereas there's actually a loss of function. Has anybody here in neuromuscular clinic seen either spectrum? What did you see? Gain of function or loss of function?
I saw both. I've seen both.
Oh, okay.
The loss of function was really interesting. He wasn't diagnosed until he was a teenager. And there were all kinds of CPS reports on the mom because he kept coming into the emergency department with unexplained injuries, terrible burns on his hands, dislocations, septic joints. And it finally sent him out for gene testing for that, and sure enough, that's what he has.
Oh, okay. Yeah, so yeah, those patients are there, and again, actually the patient I saw was a 3.5-year-old who came with a brachial plexus avulsion, and they thought that he might have a hyperalgesia, and when I talked to the mom, they had got the same history of lots of injuries and no reactions, and I tested him for hot and cold. I mean, he didn't respond to anything. I had to put the tuning fork, he responded right away. And then I was like, well, it's not that he has a hyperalgesia. He has no sensitivity to pain and temperature. And he was tested and had the same finding. So what do you think, what helps these patients with erythromelalgia? Lidocaine. Actually, there's a large report from Mayo Clinic where these patients respond very well to lidocaine patches. And actually, the patient I've seen here, we're setting him up for intravenous lidocaine infusion. And imagine you heard about it, lidocaine infusions from Dr. Brett Stacy, like helping him to set it up.
Does mexiletine work on those patients?
I had only a series of two, so have not used mexiletine. Mexiletine is another sodium channel blocker. There's a long history of Brett Gaylor, who was here and did some work on using lidocaine infusion as a predictor to mexiletine. But being in practice, I haven't found mexiletine that useful. So most of my patients end up getting intermittent infusions of lidocaine and do much better. So to move up neuroaxis, what we come is to the brain, where 20 years ago, Bushnell and Duncan have demonstrated that indeed, in 2001, they published in Science that indeed, the brain, actually in 1994, published that the brain does respond to pain. And of course, it turns out that there are networks that pain responds to. And actually, there's a very specific network that responds to particularly nervous injury resulting in neuropathic pain. On the other hand, there is nothing specific for individual patients. So all of this is a good research tool in terms of looking at groups of patients. For individual patients, there is no pain pattern. There's no pain MRI, although there was a lot of hoopla 5 years ago when University of Colorado investigators published in New England Journal of Medicine the pain networking and so on. There was a lot of looking into the fMRI will be a new pain test, but it's not. All of the functional MRI studies start with one question. The question is, does the patient have a pain? If the patient reports no pain, all of these patterns do matter. So just have to kind of make that clear. Ultimately, it does come down to talking to the patient. So why do we care to know? Why do I care to know about all of these fine details of neuroaxis? Well, actually, knowing this actually helps me figure out how do I target, how do I prescribe specific treatments if I can identify at which point of neuroaxis the problem has patient has a problem, so I can apply different therapies. So you can see that indeed we have a few options, including from transaction application of high concentration capsaicin. Has anybody used those? This is for patients with post-operative neuralgia and small fiber neuropathy. So a couple of people here. Then we talked about peripheral transmission, where opioids work is primarily on synaptic transmission, although there's evidence they work peripherally as well as upstream in a neuroaxis. So certainly there is a rationale to develop the multimodal pain therapy on understanding what the mechanisms are. So let's switch the gear to neuropathic pain. This is when I started 20-some years ago. You opened the books and there was no neuropathic pain. There was just a list of disorders that had a nerve injury as a main characteristics for them being painful. And we have learned a lot, and especially with the basic science studies, we have determined that actually there are common underlying mechanisms that are shared by all of these diseases. Ultimately, the course of the disease is dependent on offending event, be it trauma, usually it's static. But diseases like diabetic neuropathy, well, that's under the mercy of what happens with diabetes. People who do not control diabetes, the neuropathy progresses, the pain changes, and things of this sort. So again, it's really important. And again, what's interesting, although we made so much progress in neuropathic pain, FDA and all the other institutions like the NIH do the funding only depending on these etiological diagnoses rather than the concept of neuropathic pain. So what is neuropathic pain? Well, International Association for Study of Pain defined it as a pain arising as a direct consequence of diseases affecting somatosensory system. So fairly simple the statement. And although it was only there's a series of publications that came out of this body, the international body, but my first reaction was you should state, as they do now, that indeed the implication is that sensory evaluation in the clinical and research setting is the key. You have to demonstrate the presence or absence of sensory abnormalities. And so what it comes to? It comes down to what neurologists do, to a sensory exam. And then again, they proposed a grading system because this was a group of European neurologists who like to do gradings like they do in MS, tried to apply it to pain. It was pretty clumsy and not that successful. But they had this grading system of unlikely, possible, probable, and definite. And this is what the algorithm looks like. Basically, a person reports the pain. If it's in distribution of neuroanatomically plausible distribution, then it's possible. If it's not, then it's unlikely. And then if it's possible, then you will do confirmatory work, which is bedside sensory testing. If you have tools and means of quantitative sensory testing, then by all means. And then there are other diagnostic confirmations that then lead to definite neuropathic pain. As you can see, they really get fancy here in addition to neuroconduction studies, which is kind of not that relevant because it's a small nerve fiber system, A delta and C fibers that are affected in pain. A beta fibers don't contribute to pain that we can demonstrate clearly. So it's really skin biopsies, and actually CCM stands for confocal microscopy, a corneal confocal microscopy, which is again a fancy tool, as well as laser work potentials. It can get really fancy, but I would say we can do well with the bedside sensory testing, which kind of brings me to this audience. Again, I always like to learn about the audience I'm interacting with. So by raising a raise of hands, and I hope nobody takes offense to any of this, but let's start from the bottom. How many of you consider yourself an expert in sensory exam? Maybe we should take out faculties. You have to declare themselves, but okay, 2 people. They're experts. 3. How many have sufficient skills to use in diagnosing pain? 1, 2. Rudimentary skills in conducting sensory exam. Okay, 3. Had cursory training during neurology rotation. Okay. Well, actually, don't take any exception to this because I've been to different audiences, nationally, internationally. I was at the Neuropathic Pain Interest Group in Toronto 5 years ago. So these are the experts in neuropathic pain. And the session was on applying clinical assessments of neuropathic pain. And my question was, how many of you are confident in doing your sensory exam when making diagnosis of neuropathic pain? Only 30% raised their hands. So we have a long ways to go. But I think it's a lack of confidence in what we know and what we can do to really make a sensory exam a valid tool. So I hope you can join me in an effort to make a sensory exam be up to par or other neurological skills we can do. We can start with what neurologists do very well is recognizing patterns. So what does patient X has? If I tell you this woman fell through the glass door, and actually in the University of Wisconsin we have a colored pain drawings where each color designates a specific sensation. So for example, she had a tingling in her 4th and 5th fingers, and then burning down to her forearm that's extended up, and then a stabbing pain in the forearm, and then aching in her upper arm. Would it be ulnar causalgia? Yes, it is. So she had allodynia and hyperalgesia in this same area. By the way, does anybody know what allodynia is? So there's one yes. Okay, a couple of people. Does everybody know what hyperalgesia is? 1. Actually, allodynia is, and again, it's one of those things that the whole field is struggling with. Pain is interdisciplinary. We have people from anesthesia who started it, and rehabilitation medicine, psychiatry and psychology, and neurology as one of the smallest groups. But these are the terms that refer to abnormal sensory phenomena. Allodynia refers to pain from non-painful for innocuous stimulation. So like touching this woman in this area of ulnar nerve distribution will cause severe pain. She's not nuts. She has a very highly sensitized peripheral nerves as well as a lot of central sensitization. And hyperalgesia refers to increased pain perception from noxious stimuli. So if you do your pinprick, if you do pinprick on her chest or on the other arm, or median distribution of her hand, she would have a report of normal pin testing. Or if you put the hot tuning fork, she would have a normal perception. But if you would do it in ulnar nerve distribution, she would report very high ratings of pain. So that would be then hyperalgesia. If I tell you this person had a shingles, what is this? This is somebody with T4, T5 post-herpetic neuralgia, reporting pain, burning pain in those dermatomes. And then he had this extraterritorial paresthesia. Neurologists traditionally, when they see something that's outside the nerve distribution, what's our definition? What's our diagnosis? Person is making it up, right? Well, actually, now we can explain this by means of central sensitization, which takes place a few levels above or below the spinal cord segments. So he does have a primary deficit of burning pain in an area of damage from the shingles, but then extraterritorially, he has a paresthesia, which is, again, another positive sensory phenomenon. One of the characteristics of neuropathic pain is that patients have a negative sensory phenomena due to nerve damage. But at the same time, because these remaining nerves have a gain of function, remaining nerves are overactive. So in the same area, patients will have a deficit to one modality, like most frequently to large fiber function, like vibration or touch, but then they would have a hyperalgesia to pin testing or hot or cold testing. This is a young man, 32-year-old, who presented with paresthesia from his waist down, and then you look at his also same type of paresthesia in his left forearm. So lesions spread in space. What's the diagnosis? Could it be MS? Yes, that's what he had. But his primarily presenting symptoms actually sensory. He did not have any motor deficits. He did have a little bit of a bladder problem. So, and again, it's one of those things, it's diagnosis written right there if you know how to read it. So currently available tools that we can do in a clinical setting is referred to the grading system proposed by our colleagues is this, but I think we can do better than this. And we can start with the simplest thing, pain ratings. And you've probably seen, now it's a JCO standard that patients come with when the vital signs are taken that the patients report pain. And they usually use one of these scales. Does anybody have any idea what is pain rating, let's say, of 8 would mean on somebody who comes to your clinic? What does it refer to? Does it refer to burning here or hyperalgesia there?
How much it affects their life. It refers to how much it affects their life.
Very close, indeed. Actually, there's a study done in 2001 in UK, and actually it turns out that the overall pain rating has more expression of what pain means to the patient and how it affects their life than any specific sensation. Excellent, thank you for helping with that. But how do we then find out when you have so many symptoms as patients and those pain drawings to show to us? That would be indicative of neuropathic pain. There are something that's called neuropathic pain assessment tools, maybe such as Leeds assessment of neuropathic symptoms and sign scale, developed in UK, DN4 developed in Germany, neuropathic pain questionnaire we developed in University of Wisconsin, pain detector developed in Germany, all independently around the same time, identifying a number of symptoms that patients with neuropathic pain have. So you can see that patients with neuropathic pain have not one or two, but many symptoms. So if you ask them one number, they'll just put it all together and give you a number. But if you really know if they have neuropathic pain, you give them one of these. Has anybody ever heard of Pain Detect or neuropathic pain questionnaire? Well, now you do. So now you can leave. If you haven't learned anything, you can say you have learned it. these tools are developed specifically to differentiate neuropathic pain from non-neuropathic pain. And guess, there's a little story that a little simple tool, ID pain, that could. The University of Wisconsin is associated with the VA hospital and medical center in Madison, where I had an appointment. And I worked with primary care 10 years ago. And they, in primary care, dealt like everybody else. What do I do with pain? And what did they do? Have to prescribe to the patients ibuprofen or Vicodin. And we know what Vicodin has done. Then I told them, like, well, why don't you use a couple simple steps to identify patients who have neuropathic pain? Oh, that's interesting. And for example, you can use ID pain. There's another tool that was developed in the US that I helped develop. And actually it has only 6 questions, and it's all yes or no. So if a patient comes into clinic, MA or NA will ask, do you have a pain? What's your pain rating? If pain rating is more of 4, the 4 or higher, then they get ID pain. If ID pain score is 2 or higher, it's indicative that pain is likely to be neuropathic. Then actually I talked to the residents and staff. I taught them just simple sensory exam they can do in less than a minute. And what were the tools? Things that are over there in a clinic, such as tuning fork, such as cotton tape applicator. So you use the cotton tape applicator, the cotton part, you test light touch. You take the wooden part, you can test punctate, which is kind of similar to pinprick testing, stimulating A delta fibers. So you're already starting to do very sophisticated neuro exam with very simple tools. And then use the tuning fork to test the cold and vibration. So you test a pretty sophisticated sensory exam in less than a minute if you know what you're doing, of course. And I told them, be ready to get negative, less sensation for one modality and more for another modality. And guess what? That's really what you're looking for, because that's the definition of neuropathic pain. You have lost it to one modality and gain in another. And so the question was like, oh, what's the point of making diagnosis of neuropathic pain? Well, there are 2 implications. One is diagnostic, that gives the primary care doctors an indication, like, whoa, why would they have neuropathic pain? Maybe they have diabetes, they maybe have B12, thyroid dysfunction. So they give them, it empowers them to be investigative. And on the other hand, therapeutically, they can start to talk about patients about role of nortriptyline and gabapentin rather than whipping out and writing Vicodin prescription. And so they've been still doing it, although I left 5 years ago. Yes, sir.
So do you think it's worth putting much stock in how the patient describes their pain? You know, they talk about neuropathic pain as burning versus an ache. Do you put much stock in that?
Always, always. I mean, it's in my experience, just in short, is patients. Patients do not have to convince me they have pain. Actually, I totally turn the table. I really have to convince them they have a pain. And a lot of them, they have a hard time describing their pain because they usually nobody asks them. So they frequently don't have words to describe it. For me, if somebody tells me they have a lot of burning and searing pain, see, fibers are going haywire. So I'm thinking already in those terms. If somebody is having paresthesias, I'm thinking about A delta as a beta fiber dysfunction. I'm thinking about localizing where a neuroaxis the problem is. I use the pain diagrams as well as my sensory exam to lead me to pinpoint where's the problem. And absolutely, it does take a time, does take a little practice. You have to get used to listening to patients and overcome the fact that many of those patients are distressed. I mean, going back to the pain rating, a lot of times the patient will give you pain rating with 20. What do you do with that? Most people just run out. Well, I always tell patients, time out. I know you've seen 20 doctors. I know you have a pain, but I really need to know about that pain that goes down to your leg. Well, that pain, that's 7. And now you can start the discussion. And because, as I said, most of the patients, they need diagnosis. They don't need as much Vicodin or somebody to cry on somebody's shoulder. They just need to be understood. And so we do. I would suggest we can do sensory neurologic exam literally for this reason, to identify what the problem is. And I guess this is a little bit neuro trivia. Here is the micrograph picture of the peripheral nerve. And this is the histogram of the account of nerve fibers. And those who do neurophysiology, when you do your nerve conduction study, you're pretty much picking up this, correct? You don't see this. This is invisible to nerve conduction study. But if you look at, this presents only 20% of nerve fibers. These little guys, C fibers and A deltas, they constitute 80% of peripheral nerve fibers. And they're more than likely statistically to be damaged, diseased, and injured. And so it's not surprising that patients who have metabolic syndrome, who are going to develop diabetes, a lot of times present to the primary care or neurology with burning and numb and tingling feet, because these fibers are already giving the ghost. So how do we test that? Well, to do this, you can really get it sophisticated by doing the quantitative sensory testing. Most of the time, people think about machines that can deliver a specific temperature and certain ramp and so on. There's a whole science of physics, biophysics of receptors. And you can test it with simple things as a brush or tuning fork, or you can do the set of von Frey monofilaments, and now actually von Frey used the horse hairs. Now they're made out of plastic. But in any case, you can really interrogate the nervous system in terms of down to sensory channels, and go back to the question from a couple of minutes ago. Now, if I find somebody who has a burning pain, and I'll bring the case that might serve as an example, and somebody who has a hyperalgesia to hot, you are really confirming yourself in putting to the higher order of confidence that indeed this person has a C fiber neuropathic pain. And then we can take in terms of investigating what the etiology could be. Idiopathic could be deficiency of something or exposure to the other. We talked about quinolones exposure causing paresthesia, painful paresthesia, and so on. And this is the result of the study where we actually at the University of Wisconsin developed a normative data set for threshold detection as one of the methods when we investigate, when we apply quantum sensory testing. One of the things that it's important to do is also to get the pain rating at the thresholds, with the idea to really interpret the results of quantum sensory testing. A lot of the tests, like nerve conduction studies, you can do the test, and it pretty much your technician can get you waived. But how do you interpret it? It really requires somebody who knows anatomy and physiology. A German network for neuropathic pain has developed a protocol, and they have done now thousands of patients through this standardized quantum sensory testing, and they now have developed phenotypic profiles that could be enrolled in studies or analyzed in different ways. And you can see in these two profiles, subgroup 1, where actually patients who have a gain of function in one modality and loss of function in another, although they have two different diagnoses, and the same diagnosis have different pattern. And so really it comes down to the diagnosis itself might be initiating factor, but what the patient profile is really would lead to our qualification in phenotyping patient with neuropathic pain. Will be symptoms based. And again, this is nothing unusual and different than what you would see in a phenotyping patient with epilepsy. You can have one clinical manifestation. On the other hand, you have another EEG pattern, and the third thing is what you find in other investigations. So really this helps us to start to quantify and put the things into perspective.
So what was the x-axis on that?
Oh, these are the different modalities. Here is actually the different testing modalities. So this is not an axis of one of the things. So for example, there's a warm detection, cold detection, warm detection, TSL. There's different methods, cold pain detection, hot pain detection. So they have a battery of 13 tests. And so depending which test is done, although patient in this group has a post-operative neuralgia, 30% of patients with post-operative neuralgia have this profile. But patients, 11% of patients with post-operative neuralgia have a very different profile. So although it's a one etiological diagnosis, the profile is different. And that might be more similar to 16% of patients with diabetic painful neuropathy. So it's not either or, it's and And you have to take the diagnosis, but as well as the phenotypic profile. Some of the research I've done at the University of Wisconsin has been now collaborated in many other centers, is that actually going back to the immune system, and I made a reference to microglia as central elements. There's actually evidence that the periphery glia is involved in chronic neuropathic pain, and this is study where we demonstrated that CSF IL-1 was proportionally increased in its severity of pain, while IL-10 in the blood was negatively correlated. Just for those who are not familiar, IL-10 is actually anti-inflammatory cytokine, while IL-1 is pro-inflammatory. So you can see that there is, in these patients, although the damages to the nerves, their immune axis is tilted in a negative way. So this is one patient with pattern of what? Leg-dependent distal neuropathy. This patient, again, has a positive and negative sensory phenomena. She has a black heels numbness. She's very numb in her legs and feet and her fingers, but in the same area she has a stabbing pain and tingling and burning. Turned out that she had a small fiber idiopathic neuropathy. That was her burning pain that was the predominant symptom, so which indicated to me this is probably fiber mediated. On quantitative sensory testing, she had a warm allodynia. Warm testing, she was rating her pain as 8. Again, peripheral sensitization of C fibers. Her cytokine profile was similar to what I presented. She responded to IV lidocaine, overexpression, positive gain of C fibers, of the sodium channels in C fibers probably. And she did not have genetic testing or fMRI, but prediction would be that this would be the case. So that's what I'm kind of hoping, that soon we will be able to apply these tools and profile our patients kind of similar to what cardiologists do when somebody presents with chest pain. They get a chest X-ray, EKG, echo, stress test, and whole shebang. We can do this now and get much better and closer definition of what the problem with the patient is. So I hope that answers the question that you asked. And you have to start with the pain symptoms, as I did. So I hope that answered the question. Now I'll switch for the remaining few minutes to the experimental models. When we talk about the pain models, usually people think in terms of clinical models. But I don't know, probably I'd be surprised if anybody's familiar with UVB, ultraviolet burn, which is actually could be applied for like a minute or so and can induce the second degree burn similar to sunburn. But that's stable for 24 to 36 hours. We can start to test some physiological or pharmacological molecules. Intradermal capsaicin causes central sensitization, while UVB does primarily induces peripheral sensitization. I've been working with Mike Nemino from Stanford, who uses diode laser, which selectively can stimulate C fibers separately and selectively from A delta fibers. And again, we talked about quantitative sensory testing. So why did I bother to develop human experimental pain models of pain? Well, I was telling you at the beginning of my introduction, one of the frustration is in the lab you have all these molecules that work in rats, but they don't work in people. But we have so much work done during the phase 1 with normal healthy volunteers, where we expose these normal healthy volunteers to new drugs, which is at that point called new chemical entity, because it's not a drug. Drug is the only thing that's approved. So this new chemical entity, we do not know what they do to people. And a lot of times they go to the patients, but we do not know, do they have any action in people? Number 2, we do not know if there's any dose response. And then the other thing is there any ideal mechanisms? But by applying human experimental models, we can start to answer those questions. Intradermal capsaicin test, which I call pain challenge test, is done by injecting intradermal capsaicin 100 micrograms into skin, which results in this what is clearly axonal reflex. So you see this erythema. And when you test these subjects, because when you do research, they're subjects, not patients, this person will have an area of secondary hyperalgesia. It's called secondary because nothing is done there, but it's an area where a person has hyperalgesia. When you do the pinprick and hot testing, the person reports a lot of pain. So, you can see that what I do now with the CRO, we can apply the new chemical entity and find out if it does anything to these subjects. And work with Mike Nemenov, he's developed a diode laser, which is very different from a CO2 laser, which stimulates only A delta fibers. Diode laser stimulates specifically A delta fibers and C fibers. And as you can see in this elegant work, he's demonstrated that A delta fibers has a and this is done with the evoked potentials, and he has also psychophysical report of increase in pain with increased intensity with A delta stimulus, and then he switches the stimulation to C fiber protocol, and you can see that clearly there is a high correlation between evoked potential and patients and subjects report of pain from the laser. He did a very clever test when he applied topical capsaicin. Topical application of capsaicin actually functionalized the C fibers for a few hours. So when he applied capsaicin and did delta stimulation, nothing happened. But with C fibers, there was hyperalgesia. There was increase after the application of capsaicin. I mean, this is again confirmatory that indeed this method tests very specific fiber set, in this case, C fibers. So how do we apply this? For example, we know, and actually this is now demonstrated, that non-steroidal inflammatories, which work primarily to peripheral mechanisms, have effect on UVB, but no effect on intradermal capsaicin or cold pressure test or what's called a controlled pain modulation. We have not done this yet, but this is hypothetical. With opioids, they work through everything. Gabapentin does not work on a UVB, but works on intradermal capsaicin and the cold pressure test. So if you have a new drug, new chemical entity, we can submit it to testing and determine, number one, is there any response? Number two, what's the dose response? And does it work through peripheral mechanisms or both? So you can see that now we can go from preclinical laboratory kind of rat research to people, but actually making this intermediary step before we go to the patient and give them this new chemical entity, new chemical, that we hope is a drug, knowing that there is a dose to it, that we can dose the patient more appropriately. Again, I imagine that most of you are not aware, but there was over 150 clinical trials conducted last 20 years. How many of them led to the approval of new therapies for neuropathic pain?
0.
It's not that bad. That would be bad. 5. And actually, 4 of them are repurposed, like gabapentin, duloxetine. There's only one new chemical entity that went from the lab to people, which is zaconotide. Anybody heard of zaconotide? Prialt, calcium modulating drug that's administered intrathecally. Again, it's not a big success. It's a highly specialized drug that has to be delivered through the pump, very narrow therapeutic range. So the problem is, and now we can understand that how big problem we have. Billions of dollars were spent. It's now verging on unethical for us to do research without really having an idea of where we're going. On the other hand, we talked about the urgency of 45% of people surveyed thinking about suicide because their pain is unbearable and they have no access to care. So this really gives us a different perspective on unmet need. I mean, again, I don't know if you heard of an Institute of Medicine report on pain published 3 years ago. It was published, again, identifying that there's over 100 million Americans who suffer from chronic pain at any given time. And with the cost of $650 billion to our society. So it is a definitely unmet need. And so I'm hoping that through means and tools of, if you look at it, this is a lot of good old neurology, how we can make advancement in applying true and proven neurological tools to advance the field. I had to kind of make a comment about the therapies. And again, there's nothing new, as we talked about it. But how do we apply these therapies? Just to kind of give you a little kind of high view overview. There are a number of guidelines and protocols. And there's a couple of things that I participated in treatment guidelines. This one was by American Academy of Neurology. But ultimately, yeah, these are all mostly approved drugs, but what your patient gets really doesn't matter what the guidelines and protocol are. It's basically what their drug utilization office approves. So I'll finish with the case I saw just 2 weeks ago. And just to kind of put things in perspective a little bit. This was a 45-year-old man with complex medical history. He had endocarditis, aortic valve replaced. And then he was sent to me by local primary care doctor with a complaint of left thigh pain and left hip pain. And then he said, when I talked to him, he said, oh yeah, I hurt all over. And his question was like, Doc, I mean, he was actually working on a shipyard. He was a painter and a sandblaster. I don't know what they do, blast something or the other. So his question was not, can I have Vicodin, or, but his question was, do you think I can go back to work? And if I ask for disability, what do I ask for? And I had a fellow, and we spent a little time show and tell. These are new diagnoses. I sent him to his primary care physician and made a phone call. Did he have one a neurological problem? Well, he had a left neuralgia peristhetica. That was obvious. I mean, he had a pain that was just like on his left lateral. He was actually wearing a lot of belts, so risk factor was simple in there. He had a hip that would not move at all, so he had probably osteoarthritis of the hip. His left knee pain was referred pain because reproduced by exacerbating his pain. In his hip or a thigh produced a knee pain. He had a mood disorder that he didn't tell anybody, but probably had a bipolar versus anxiety. He was starting to see psychologists. I asked him, did you talk to them about your mood swings? No, but I think you should. Turns out that his wife said, like, by the way, like, usually every other day he can't talk. He just kind of phases out, like, oh, by the way, when he had his endocarditis and a heart valve replaced, somebody told him he might have had a stroke. Whoops. Well, he has intermittent fluctuating encephalopathy. And we know, I mean, he's at risk that he could have had a stroke, probably had a stroke, because he was apparently for a few days awake on the left side and didn't talk well. So he needed neurological evaluation, if nothing else for that. He had a widespread pain when we examined him. He was literally hurting all over. What's the diagnosis for pain all over and tenderness all over? Fibromyalgia. Actually, 10 years ago, making the diagnosis was like, I don't want to deal with it. Well, nowadays, it's a really elegant way to practice medicine because we have not one, but 3 medications specifically approved for fibromyalgia. Most of these patients are really interested to do for themselves. And I don't know if you're going to be surprised if I tell you the most common thing I prescribe in my practice is Tai Chi. What most patients really need is to activate, to get engaged. So this is a very simple way, and patients with widespread pain do well with that. So just to kind of give you an impression that this patient couldn't make anybody just run out of the room. But on the other hand, at the end he cried and said, well, can I apply this to the disability? Which diagnosis? And well, any of them will do. Would disqualify from being able to engage in the workforce. So I would, again, just wrap up with the comment that yes, indeed, neuropathic pain is a complex challenge, but we have tools to start to tackle it. And as I made the earlier comment, the world will see a better day and make a progress only when neurology gets involved. And thank you for your attention. Any questions, comments? Yes.
A question about intravenous lidocaine.
Yes.
So helpful for what? How does one get it? And who gets to dose it?
The question is intravenous lidocaine. How do you refer? Who do you refer to for intravenous lidocaine therapy? And who is the best patient, and how do you go about doing it? I have 20 years experience in administering intravenous lidocaine. So does Brett Stacy, who is medical director here. I was here 2 months ago. My recommendation is patients with neuropathic pain, period. So if somebody responds to gabapentin, that's easy. But patients who have, and actually my practice in Wisconsin, lidocaine was second after gabapentin that I would prescribe. If they do not respond to gabapentin or duloxetine, they get lidocaine. Keep in mind that, again, as most of the research has demonstrated, that any therapy, not everybody responds. That's not unusual for anything in neurology, so why would pain be different? But the way we do it, we do a trial run. Patient gets administered 5 milligram per kilogram over 30 minutes. And we stop either if pain stops, or if person has any side effects, or if they finish at 30 minutes. Those that get what the patient considers substantial pain relief, then schedule for intermittent infusions. And we will do that at a pain center.
Can it last for how long?
It lasts anywhere from 45 minutes to what I had a patient of 6 months. She had a thalamic pain syndrome from skiing incidents, embolus from carotid dissection. I had a pure thalamic sensory syndrome. And she received the treatment once. She moved to Arizona, and she would come every 6 months from Arizona, get her infusion, and go home.
How could that work?
I have done some work on that. Actually, well, there could be a whole grand rounds in its own right. But there is, I've done a very small study demonstrating clearly that the pharmacological effect outlasts, pharmacodynamic effect outlasts the pharmacokinetic effect. The drug is very predictable. It distributes quickly and metabolizes quickly, but the pain relief in every patient is prolonged. And definitely and actually there's a work done at UC San Diego by Tony Yach and what's his name, Srikarts in Harvard, demonstrating that there is a significant, not only peripheral effect, but significant central spinal cord effect. And there's probably effect to its metabolite, MEGX, not lidocaine itself alone. So there's a lot we have learned, but there's still a lot for us to learn. But again, take it as you may. Follow-up question.
What about intravenous ketamine?
What about intravenous ketamine? Yes, I have a paper published on that topic too. Yes, it does work. But intravenous ketamine is a little more tricky. Just for those who do not know pharmacology that intimately, ketamine is primarily NMDA receptor blocker. As I made a reference, glutamate is an important part of sensitization process and long-term potentiation that happens in the spinal cord and centrally that leads to maintenance of chronic pain. So that's the basis of applying something that would be an NMDA blocker receptor. That's probably the only and the best NMDA receptor blocker. Ketamine is used primarily in induction of anesthesia. There is at least now a decade of literature where people have used for chronic, and actually a lot of times in the battlefield or in cancer therapies, ketamine infusions are given as either sole or an adjuvant to therapies. That's another thing that we might be setting up at a pain center, but that might take a little more time because it's more tricky. It's basically anesthetic that because at the smaller doses it serves as an analgesic, and at the higher doses it's anesthetic. So dosing gets a little tricky. Patients get psychokinetic effects. In my experience, people with PTSD have very abnormal reactions, so you have to get ready to deal with that part. While lidocaine is very simple in terms of side effects being dose related. So first side effect from lidocaine is the paresthesia. If you reach that, you can stop the dosing, and it's 5 minutes later, it's all clear. But with ketamine, things kind of get a little more complicated and longer acting.
Because of time, some people have additional questions, they can come down, but thank you for your time.